I love that each of you is bringing your experience, theoretical, and treatment orientations to the table, and everyone is finding these little glimmers of different ways this case could be approached, which is so wonderful about case consultation because it allows the therapist, Steve, to hear about other, types of therapy or other perspectives that might assist this client that he's either not exposed to or hasn't tried.
Welcome to the Colleague Down the Hall podcast. This episode is sponsored by the Collab Oasis Clinical Consultation Groups. Hi, I'm Jeanene Wolf, and I'm your colleague down the hall. I have a passion for helping fellow therapists get the clinical and collegial support we all need to do this work. And wow, it just keeps getting harder every day. I'm the founder and facilitator of the Collab Oasis Clinical Consultation Groups. I have been a social worker for almost 30 years, and I own a successful solo online private practice. More of us than ever are practicing in solo or online practices, and we all need colleagues to process cases with, commiserate with on those really hard days, and also to celebrate our successes with. In this podcast, I'll bring you insights about trends and changes in our field and sit down with amazing therapists who are doing amazing work. We'll discuss fictionalized cases, ways to practice sustainably, and of course, there will be plenty of laughing. I love laughing with friends. I'm so glad to have you as one of my colleagues down the hall.
Once again, welcome. We have a great group of therapists here today that we're going to be able to dig into this case and see what we think about it. So, John is a 40-year-old male who has been in and out of therapy since he was a teenager. The therapist, Steve, has been working with him for 9 months. John presented with a long history of treatment-resistant depression and has never found any significant relief from his symptoms, in spite of trying a variety of pharmaceutical therapies, as well as ECT and TMS, and more recently, ketamine treatment. John is tired of the toll all of this has taken on himself and his family, who are very supportive of him. He does not have any hope that his depression will ever improve and believes some people are just not meant for this world. He has had suicidal ideation for many years and also has a plan that he tells the therapist he plans to utilize in the near future. Okay, so does anyone have any clarifying questions about this case scenario so far? Okay, so let's jump in. Stephen is saying, I just met with this client and I have some concerns about this. I would love to hear input about how I can manage this client because my mind goes in lots of different ways, right, Steve? It's like you can think of lots of different
Absolutely.
things. And so he wants to make sure that he's getting good consultation because this is a tricky case that has life or death implications. Does anyone have any thoughts? What are treatment concerns? What are suggestions that you might have? Do you have questions for Steve about this client? Oh, there you go. Yep, that's it. Perfect.
So I just wondered how the client was diagnosed, some type of bipolar, major depression recurrent, how they're diagnosed.
Gonna say major depression, recurrent, severe.
Okay. Without psychotic features.
Without psychosis, yes.
All right.
And he was diagnosed, he's been struggling with this since his teen years.
And he's had inpatient treatment before or partial?
Yes, he's done inpatient treatment before, yes.
Yeah, I was just wanting to know, he said he's been in treatment since he was a teenager. I was just wondering, just in terms of a little bit more history with him, just to find out some of the things that he went through as a teenager during his depressive state, if maybe perhaps a life graph was introduced just to get a little bit more clarity of his experience and his core beliefs about self.
Yeah, life graph would be great. Getting a history would be good, absolutely.
Yeah. I was just wondering that only because sometimes when, just a little brief scenario here, just to dig in a little bit deeper, because if he's been dealing with this as a teenager, maybe going back to see what's happened and his core belief, because a lot of that stuff starts then, and trying to figure out what that core belief is about self and seeing how you can move forward through that and, move forward based on that information.
Yeah. And let me just throw in, for the purposes of this case, let's presume that the therapist over the years have thoroughly explored any trauma background and there's no significant trauma in this client's life.
How about substance abuse? I think that might be interesting to know. And that has some long-term effects in terms of depression, sometimes dopamine and all that. So
the gist that we're getting, and correct me if I'm wrong, Steve, is that this really seems to be more biological. Like he was predisposed to depression. It's something that's been there his whole life. He's seen so many therapists over the years who've tried all the different things. No one has ever been able to give John any relief.
That sounds about right. Yeah. So then, yeah, everything we're trying, nothing seems to be working in the long term.
Okay.
Has mindfulness been tried?
Yes.
Has working at this from a physical activity level ever shown him any relief? Because
Can you tell me a little bit more? What do you mean by
Steve?
physical activity?
physical activity, walking, running, something where he's engaging physically in an activity on a regular basis, because we, so many studies show it's as good as medication for many people, or better.
Yes, well, we've done that. It has some short-term efficacy, and then it drops back to baseline after a little bit.
Okay, and the next question I would have is, what's the family history? Does he have either parent who also struggled with this? Or does he have siblings who struggle with this?
Let me just reread this case real quick.
Doesn't say, Steve, so you can decide what the family history is. It does say that his family is supportive of him in his dealing with this depression over the years.
Parents have been treated for depression, but not long-term. Seems like they had a couple bouts several years ago, but it was relatively easily resolved.
When you say with the physical activity, some short-term gains, but not really sustainable, as in the activity isn't sustainable, like he doesn't stick with it, or feels better for a little while, but then it doesn't last.
He will stick with it, and whatever benefit he has had, the depression will just come back up.
Okay, so any other clarifying? Go ahead, Marlo. We're going to say something?
I don't know. I just feel like some of this stuff is just kind of the unknown. I guess that's why we're exploring and asking these questions, because when you say everything has been tried, has really everything been tried, I guess? It's just too much. I feel like it's just a lot of in between we don't know to kind of provide a really good input about the case. I mean, it says pharmaceutical, we went through that. As far as ECT, you said mindfulness didn't work. Cognitive behavioral therapies, reality therapy, perhaps, maybe, assessing that, or has that been tried, where we're actually doing the wants and analyzing and looking at how are we going to get to these points and discerning from that time whether what you're doing is actually providing you what you want. So have those things been tried? Because when we say everything has been tried, there's
Marlo,
a lot of things in our pocket.
Can you tell a little bit more about reality therapy?
Just really reality therapy, and acknowledging that we have a choice. We have a choice to, in a combination with the mindfulness, saying that, we could choose to change our way of thinking. And for example, for depression, not saying we are depressed, but saying we are depressing. In that case, and acknowledging that we can make a choice to not be depressed and kind of just focus on what we could do in activities for us to not just feel all of those symptoms in a way.
Okay, cool. I'm not familiar with reality therapy too much, but would definitely love to look into it, get some techniques, and see if this would be effective for John.
Great.
Does he have any foundational religious or spiritual strengths that he leans on in any way?
Raised Catholic, but currently secular. So none currently, no.
When he's had remittance from the symptoms, his experience, he has a history, unfortunately, of going up and down, we would say. Life is good, and then a lot of life is really hard. Would that be fair to say? So when he has remittance from the symptoms, does his life change as far as how he engages in it? Is there a big differences? Do you understand what I'm saying? I may not be wording this really well.
I'm just a smidge confused. Let me repeat it back to you, and you can tell me if I'm understanding it correctly. So in regards to when he's on an upswing, if he gets one, are there any actual changes in his life?
Yes. And how he engages in it, his activities and such.
Well, what really seems to happen is we'll give a technique or a coping skill. It'll have some short-term efficacy, and then it'll lose efficacy over time. So the techniques are what's really changing, but in regards to basic lifestyle, nothing really seems to change there.
Steve, the case is that he's never had any significant relief from his depression. He's had, like you described, some of these short-term, relief, but never anything significant enough that he felt like, oh, wow, maybe I'm going to have quality of life at some point.
I've got an interesting question, and that is, has he ever made a suicide attempt, a serious suicide attempt?
I'm going to say no, or at least I don't know of any. This plan that he has in place that he is threatening will be his, at least as far as my knowledge, this first time.
I'd like to say a little bit about why I asked that question, and I'm reflecting on a client I'm pulling my hair out about these days. I've been working with this person for a while, and one of my frustrations is that we have tried, I'm not going to say everything, but a lot of things, and the person has been on a lot of different medications, but they never stick with any treatment for very long. They're not willing to, seemingly the person may have something invested in being chronically ill or in having this symptom. And sometimes I wonder if it gives them a way of controlling their life in various different ways. I've wondered if there was an obsessive compulsive component to it, or if mood stabilizers would be a helpful approach to take if the antidepressant medications aren't working, if that's been looked at, and whether or not it's really a personality disorder, which I hesitate to say. And these days we think more about complex trauma. But I guess I wonder about, in my client anyway, I wonder about secondary gain sometimes. What would a person be giving up to give up being severely depressed all the time?
Yeah, that's genius. I love this. Definitely can see maybe some personality components here, and maybe something like a variant of Munchausen, some level of, as you said before, secondary gain. Because right now our boy John has a lot of attention coming his way because he's so sick.
The client I'm thinking about actually, I think, has a significant amount of control over her family and the people she works with and things like that. They alter their behavior around a combination of anxiety and depression. And recently she's decided she's going to try another therapist other than me. And I'm like, oh, really? Yes.
That can feel like a relief, right, Caroline?
Well, I have to be really careful. I said, I'm neither trying to give you the bum's rush, nor am I trying to cling to you, and you have to make your own decision. So she's going to interview some other people and make a decision about it. But yeah, I think at this point I'm treatment resistant.
I think all of us have probably been there at some point.
Yeah.
And also, I was wondering if this client here in this scenario, we talk about how they've been introduced to a lot of things and things haven't stuck with long term. So I'm questioning the willingness for the actual client to accept and want change. Are these interventions being introduced to this client, and maybe is the client kind of, for lack of a better term, giving up and not really going through and seeing the interventions all the way through to show efficacy? And so I'm wondering if that is maybe possible with the situation with the client as well.
Yeah,
absolutely. Okay, so both really good points. And I would say, with permission, with HIPAA and release of information, maybe psychosocial history from the family, both Caroline to see what's kind of control dynamics are there, and Marlo to explore, well, is there a history of this? Is there what did this guy actually accomplish? Or is this a repeated pattern of behavior? Or rephrase that. Is he giving up? Yes. Has that been a repeated pattern? Yeah. Was that correct how you were trying to say that, Marlo?
Mm-hmm. Yes.
Okay, cool. Thank you.
I noticed in the treatment that EMDR hasn't been mentioned. Has that ever been used? Because approaching that from a blocking beliefs perspective might be in service to uncovering some of what's beneath.
Okay, and can you tell me more about how would you go about utilizing EMDR and blocking beliefs?
His belief that some people aren't meant for this world would be a good starting point, and going beneath that.
Okay, cool. Thank you.
I would just like to point out that I love that each of you is bringing your experience, theoretical, and treatment orientations to the table, and everyone is finding these little glimmers of different ways this case could be approached, which is so wonderful about case consultation, because it allows the therapist, Steve, to hear about other types of therapy or other perspectives that might assist this client that he's either not exposed to or hasn't tried. So I think that's wonderful, the way you all are bringing all these different elements in. Okay, so for the purposes of taking this a step further, let's presume all of the things have been tried. At this point, John is saying to Steve, I'm tired of being everyone's guinea pig. My family is supportive. I get that you're trying to help me. I don't see change on the horizon. And I really feel like the best thing for me to do is to go ahead with my plan. So this is where we're at in the present moment. Thoughts, next steps?
Well, obviously I would think you would have to explore whether a higher level of care is appropriate, be that partial hospital or inpatient care, and whether or not you might need to pursue that involuntarily if the client's not willing to pursue it. So they've said enough that if something happened, you would be very liable.
Okay. So if somebody wants to contemplate suicide, is that enough to break confidentiality?
If they express a plan and intent in the near future, yeah, I would say.
I agree too. And of course, we have to pay attention to our own state laws and regulations at the same time. In the state of Georgia, absolutely.
What I've done in situations like that in the past is to run the case by somebody in emergency services in the local community services board. They will just about always tell you you need to file a petition under those circumstances because they don't want to be liable. The problem I've run into in the past year or two is that often the police won't pick them up on an ECO because they're so busy. That's a fine situation to be in.
Absolutely.
But I think you have to go through the motions and be able to document everything that you've done to deal with it. And also, if you have a release with a family member, being able to talk to them or having them come into a session with you too might be a way of evaluating that, or having the person go to partial as opposed to inpatient is a way of having them evaluated day by day. So it's less threatening than being locked up. And it also gives the opportunity for group therapy, which might never have been tried, and for daily evaluations as to whether they're safe enough to go home.
Does the client's right to self-determination come in play here at all?
I actually want to answer this because I worked in palliative care for a year and a few months. And one of our cases, we don't have euthanasia here, but they do have in Canada, Denmark, other places. And I get it. Adhere to the state laws, adhere to the federal laws, listen to your board, all that stuff. But that one, especially with international travel, that might be an area to discuss.
And I think that would need to be decided by the state agency that would evaluate whether they needed involuntary care or not. In the end, your decision is only whether you're going to refer the person for involuntary evaluation.
I was recently listening to a podcast between a trauma therapist and a suicidologist, and their perspective was that in most states, a client being suicidal is not enough to break confidentiality, that the laws can be really specific around that. So I agree that you would really need to know your state laws, because you have an adult who is not in any type of psychosis, who is presenting with a long standing history, and they're saying, this life is miserable. I don't want to live this life anymore. And under that scenario, can you break confidentiality? And again, this is going to involve people's different perspectives and probably also your licensure type. I think there might be some differences in social workers versus psychologists versus licensed professional counselors. And each of those types of licensure have guidelines about how you manage a case like this. So clearly this is a very complicated situation. And I really feel for Steve because this is really stressful. There's a lot at stake here, but you also are trying to, support the therapeutic alliance you've made with this client and respect his perspective.
I think imminent danger is, I know in the Virginia laws anyway, that phrase is in there, and it's been interpreted different ways at different times. Right after, where was the thing? Charlottesville, I think there was right after that, they actually retrained, and they may have changed the state regs about that to some extent, and they were calling it a lot tighter than they were in the past, and they've loosened back up again because of the economic situation and COVID, frankly. But I think imminence makes a lot of difference. If there's substantial evidence that they're going to be a danger to themselves or others in an imminent way, that's a real key. If they are saying, I'm going to do it soon, I've got it planned soon, that makes a lot of difference.
Okay. Would the scenario change if kind of what Steve was referencing, that this is a person who has had really compromised physical health for a very long time in such a way that there is no potential relief for the physical implications of the illness that they are experiencing, that the doctors have basically said, there's no hope that we can make this better for you. This is sort of like, this is the best it's going to get. Does that change anyone's perspective, or do you still feel the same way?
I feel like that becomes a very, very slippery slope and a very gray area, because how do you, whoever you, make the distinction between the physical part versus the mental health part, and where is that line fall of when it becomes, okay, this is the best it can be versus their mental state at the time. And I think it's the very gray area.
I agree. And I think also, just like you say, it really just depends on what's happening. You're talking about somebody who's coming into psychotherapy, but if you're talking about somebody who is, I don't know, they have cancer, for instance, suppose he had cancer, and you still have to go by the state, and like in the state of Georgia, we can't do that. One thing I could tell you, that I've been with hospice for over 25 years. I run a hospice inpatient unit, and we can't do it. We just can't. It just is what it is. I have patients all the time. I have patients today, right now at the inpatient unit. And no hope, but they're on hospice. It just depends. It's just that you are so right, Andrea. It's just such a slippery slope.
Absolutely. Yes. So I want to thank you all for your participation in this case. This again highlights the complexities of our work. One of my major frustrations when I do ethics training is that they give you all the scenarios of ethical conundrums and there's no right answer. And so I typically leave there feeling worse. Like, okay, you told me all the things that can go wrong and the things I need to consider, but there really is no right answer. And so in a case like this, it's super important that we consult with colleagues. And that is in your best interest, not only in the way you're managing the case, but for yourself and your license as well. Because if someone were to investigate a case that you were managing and you went to court or your licensing board was investigating it, they're going to say, how would your peers have managed the same case? And so in a case like this, especially, it's so important that not only do you meet with colleagues, but that you document that consultation. Specific names of who you met with, the date, what were the considerations that were discussed, what were the legalities, what were the ethics, the client's right to self-determination, all of those things that were discussed. And then the therapist deciding to either continue the treatment plan as it was already, being implemented, or a new course of treatment was taken based on the consultation. So there is no right answer today. I think there's so many facets of this that can be really difficult. And so I want to thank you all for going through the different scenarios with that.
Thank you. This was fun. I really appreciate this.
Good. Yes. Go ahead, Marlo.
I would just want to say, this is me just being Marlo. My personality just talking to you guys for real now, okay? Mm-hmm. Straight up.
Yeah.
Okay. Like, this is the way I feel. In Georgia, yes, LPCs, we could 1013 our clients and this, that, and the other. And I 100% agree about the documentation. Like, if I was in that situation with the client today, I'm going to call everybody I need to call. I'm going to figure out some things. But at the end of the day, I'm going to trust my gut. And if I feel that I need to 1013 somebody and somebody be mad at me because I did it to save their life, because I do not know whether or not they're truly going to do it, then daggone it, I'm going to do it. It's almost like saying that you have a best friend, your best friend, you guys are out, she's drunk, right? Mm-hmm. Do I care that she's going to be mad at me if I take her keys? She could be mad at me all she wants.
Yeah, absolutely.
But I'm not going to take that chance. Yeah. So I don't know how you guys will receive what I just said.
Yeah. Well, Marlo, I think you raise an important point, and this comes up over and over in our field, is that our instincts, which have come from years of training and experience, also intersect with our values. Okay, we can't take our own personal values about humanity and what people deserve or should reasonably expect from a therapeutic relationship. And there are times that our ethics and our values might clash. And a couple of cases ago, we kind of got into some of that. And so that's why the consultation, documenting do a review of your laws, do an ethics consult with your professional body or your liability insurance company, do a literature review, like use all of the resources at your disposal. But keeping in mind that we are also humans and we can't take our humanity, our values out of the equation, nor should we necessarily.
I have a question with that, and I guess kind of just more from a practical standpoint, consulting with all of the colleagues, with your licensing board, with state laws, all of those things. And this might kind of sound silly, but just from a practical standpoint, okay, that all of that makes sense, and all of that are things that we need to do and should do, but how do you reconcile that with, like, if this person's sitting in your office and saying, like, yeah, this really likely might happen soon, whether that's today, tomorrow, next week, like, how do you, and I guess there's no right answer, but just I'm curious how each of you would approach that, because there is sometimes I feel like that sense of urgency, and you can't just get a bunch of colleagues on the phone and don't leave my office yet until I figure this out.
You can attempt to do that, and you can document that you've done that. You've asked them to wait, and that's, you can't restrain them yourselves, but you can have somebody in the office, or you even can call 911. And if they leave, they leave. That's just like if somebody leaves your office drunk, you have some obligation to do something about that.
Well, in fact, and that's a good point with it was a while back though. It was not a drunk situation, but if I know, for example, that a client has come into my office or whatever, and I know from the beginning that we're not having a session. It's just not happening. Mm-hmm. Number one, we can't have a session when you're drunk or intoxicated. You just can't, so it gets, just like you say, Caroline, it really depends. And we don't know. I mean, we taught in school, and we all know that we never know if they're really going to do it. We never know.
Yes.
How do we discern?
They may not know. They may not know. Right. And when somebody's that fragile, any small thing could make a difference and stuff. So I do think it may be helpful sometimes to explore what suicide means to a person. Mm-hmm. Did they see that as relief from all pain? Mm-hmm. Are there other ways that they can get relief from pain, at least briefly, that might allow them to hang on for a while longer, and to look at what suicide means? And one of the things I say to people sometimes who aren't actively suicidal, but maybe it felt that way before, is sometimes I feel like it's a safety mechanism people use to say that they're suicidal, because it means if it got terrible, if it got so I couldn't stand it anymore, there would be a way out, and that makes them feel safe enough to keep on trying.
Yes.
And if that's true with a person, then maybe you don't necessarily have to go the involuntary route if you can put together plans and contact a relative and things like that. But what suicide means to them and how imminent it is, I think, are the real important things. And I've been in a number of these situations over the years, and it's hell for the therapist.
Yeah, absolutely. Yeah. And I think that is something that we don't talk about in society. The relief somebody who's really struggling might feel, that maybe they don't even want to kill themselves, but they just wish they would go to sleep and not wake up, and normalizing that that's a coping skill, that knowing that sense of relief, that if things got really bad, there is an out. Not that I have a thought about really doing it or a plan, but it's a relief to know maybe I wouldn't wake up one day. Maybe I wouldn't have to be dealing with this one day. Okay. Well, thank you all again. That was a really great conversation. There's so many complexities in the case like this. And it's so hard as a therapist to take that on and to know that there's a lot at stake when we're doing this work. So I thank you all for sharing your experience and your perspectives today.
Thank you so much for listening to the Colleague Down the Hall podcast. For show notes, links, and downloads, head over to colleaguedownthehall.com, where you'll be able to learn more about getting the clinical support you need and resources to help you work in a supported, sustainable way. If you've enjoyed this episode, please share with your therapy friends and colleagues. Subscribe to the podcast, and if you love this episode, please leave a review.